Welcome to the Explainer. Today we're unpacking a truly fascinating document that reveals exactly what it takes to become a pediatrician. You know, when we take our kids to the doctor, we just kind of expect expertise, right? We expect empathy, a steady hand. But how is that doctor actually forged? Well, today we're going to look at that process not just as regular medical school, but as a grueling, multi-layered hero's journey. We are going to decode the exact training matrix, specifically the 04-113 Pediatric PGY2 training document that literally transforms a medical school graduate into a highly specialized guardian of children.
To really grasp the weight of this journey, we have to start right at the source. This is an official mandate from the Ministry of Health and Welfare, complete with the red seal and signature. And I want to emphasize right off the bat that this is definitely not some loose set of suggestions or a rough kind of make-it-up-as-you-go syllabus. No way. This is a rigid, highly demanding, government-issued mandate. It's a legal and professional framework designed to guarantee that the doctors protecting our absolute most vulnerable population are tested, trained, and refined to absolute perfection.
So, to make sense of this incredibly dense 24-page matrix, here is our roadmap for today's explainer. We're going to break the resident's journey into 5 distinct phases of medical mastery. First, a pediatric training overview, then essential clinical skills, moving from newborn to adolescence, acute and chronic management, and finally, medical ethics and protection.
Okay, let's dive right into Section 1, Pediatric Training Overview. Let's talk about the sheer volume of time and the intense environmental stress these doctors face right from day one.
This blueprint basically dictates their entire lives for several years. It breaks down the specific rotations for resident year 1, year 2, and year 3, often called R1 to R3. And you can really see the dramatic escalation in pressure here. In year 1, they spend 4 months in the general pediatric wards, only 1 month in the ER, and 0 months in the intensive care unit. But as you track their progression into years 2 and 3, man, the training wheels completely come off. By year 3, their time in the general ward drops to just a single month, while their time in those high-stakes, incredibly heavy-pressure environments of the emergency room and the ICU actually doubles. They are systematically pushed right into the deep end.
And all of this intense rotation happens over a strict minimum of 3 years. 3 years is the absolute baseline requirement just for this pediatric training phase alone. It really sets the stage for this compressed, intense crucible where every single month is meticulously mapped out to build a doctor who simply will not break under pressure.
Moving on to Section 2, Essential Clinical Skills. Now that we know where they spend their time, we really need to shift our focus to the intense what. Like, what must they physically do with their hands to survive this training? These are absolutely not just abstract concepts they read about in a textbook. These are highly invasive, high-stakes, essential procedures they must physically master. We're talking about intubation, literally sliding a breathing tube down a tiny, fragile airway, placing central venous catheters, inserting chest tubes to drain fluid from around the lungs, and lumbar punctures, which means carefully inserting a needle right into the spinal canal. Now, doing this on a grown adult is hard enough, right? But just imagine the extreme physical precision required to perform a lumbar puncture on a squirming toddler or placing a chest tube in a premature baby. Now, what's really fascinating here is how the curriculum guarantees that level of precision. It doesn't just vaguely say, hey, learn how to use an ultrasound. It demands strict, documented procedural counts to build that life-saving muscle memory. A resident has to perform at least 5 brain ultrasounds, 5 kidney ultrasounds, 5 cardiac ultrasounds. They have to log exactly 3 successful lumbar punctures and 3 central venous catheter placements. They are literally building a physical muscle memory matrix. Why? So that when an emergency strikes, their hands know exactly what to do before their brain even has to think about it. The ultimate goal of all this intense repetition is captured beautifully in the curriculum's ethos. The mandate clearly outlines the evolution of the resident, starting from a first year who merely observes and assists to a third year who must flawlessly and independently execute these invasive procedures under extreme pressure. There is absolutely no hand-holding by the end of year 3. They are the ones holding the needle.
All right, let's step into Section 3, Newborn to Adolescence. This highlights perhaps the most unique challenge of pediatrics, and honestly, what truly separates it from adult medicine. It's the terrifyingly vast age and developmental spectrum of the patients.
Just picture this contrast for a second. A pediatrician might start their morning performing delicate neonatal resuscitation on a 500-gram premature infant whose lungs haven't even fully formed yet. That patient can't speak, they can't point to where it hurts, and they require microscopic, incredibly precise adjustments to their environment.
Then, that very same afternoon, that exact same doctor might be treating a towering 18-year-old high school athlete dealing with complex psychological issues, substance abuse, or depression. Pediatricians basically have to master multiple different human species across their physical, hormonal, and psychological development. It's mind-blowing.
We see this stark contrast directly in the source text. On one hand, the perinatal care matrix demands total mastery over incubator settings, maternal blood types, and newborn jaundice. And then, right on the other end of the spectrum, the adolescent issues matrix requires the doctor to be fully trained in recognizing eating disorders, body image issues, and even cyber addiction. The sheer breadth of knowledge required here is just absolutely staggering. They literally have to be neonatologists and adolescent psychologists all rolled up into one person.
Let's move on to Section 4, Acute and Chronic Management, and see how this knowledge builds into the really terrifying world of disease, poisoning, and accidents. Because, as we'll see, a pediatrician isn't just there for routine well-child checkups. They are the frontline defense against the totally unexpected.
The training matrix lays out these incredibly specific, terrifying scenarios that these doctors must be fully prepared for. They are strictly evaluated on crisis management for things like venomous snake bites, carbon monoxide poisoning, classifying and treating severe burns, and managing the critical ICU aftermath of a child drowning. The curriculum lists these out explicitly. It's to ensure parents know exactly why these doctors are qualified to save their child on literally the absolute worst day of their lives.
But, saving a life isn't always about dramatic cinematic trauma like a snake bite. Often it's about extreme mathematical precision. The text focuses heavily on fluid and electrolyte management. Think about it. When a tiny child's kidneys are failing or they're severely dehydrated, the doctor must calculate exact microscopic fluid drips. A tiny miscalculation of sodium or potassium in a small body can be instantly fatal. They are solving complex, high-stakes biochemical math equations right at the bedside, ensuring that the internal tides of a child's body stay perfectly balanced.
Finally, we reach Section 5, Medical Ethics and Protection. We need to take a moment to address the heaviest burden these doctors carry, because beyond the intense medicine and beyond the complex math is the emotional, ethical, and legal protection of children.
The matrix specifically mandates training in clinical ethics, highlighting tools like Jason's 4-box method. You see, they don't just learn the hard science, they actually have to learn a formalized system for making completely impossible moral choices. When a family is facing a devastating end-of-life decision for a terminally ill child, or when medical treatments conflict with patient autonomy or parental rights, the doctor can't just guess what to do. They rely on these highly structured ethical frameworks to navigate the most heartbreaking, difficult conversations a human being can possibly have.
And tragically, sometimes the biggest threat to the child isn't a medical disease at all. The matrix outlines incredibly rigorous requirements for identifying child abuse, basically demanding that pediatricians act as medical detectives. They're specifically trained to identify hidden signs of physical trauma, emotional neglect, and sexual abuse. They're taught exactly how to document these injuries and the proper legal channels to report them. In a lot of cases, the pediatrician is the ultimate and sometimes literally the only shield a child has against a dangerous home environment.
The text even mandates training in some incredibly dark and complex psychological realities. For instance, it specifically highlights conditions like Munchausen syndrome by proxy. This is a chilling, severe form of abuse where a parent or caretaker intentionally makes their child sick or completely fakes symptoms just to gain attention or sympathy from the medical staff. Training a doctor to look past a devoted-seeming parent to actually see the abuse hiding in plain sight, that requires immense psychological insight and serious professional courage.
And this brings us to the community child advocacy requirements. This brilliantly illustrates how, by their 3rd year, these doctors are officially mandated to look way beyond the hospital walls. They aren't just treating patients in a sterile vacuum. The curriculum requires them to actively coordinate with schools, to deeply understand available social resources, and to work right alongside social workers to improve the holistic, everyday environment the child actually lives in.
So, is a pediatrician's job only inside the hospital? Absolutely not. A pediatrician isn't just a doctor quickly prescribing antibiotics. They are biochemical mathematicians, ethical guides, and lifelong community advocates. So the very next time you sit in a pediatrician's waiting room, ask yourself, how many intense, unseen battles did that doctor have to fight just to earn the right to protect your child? Thanks so much for joining me on this explainer, and as always, keep learning.